start, let me ask you, how many of you all know who Dear Abby is? Everybody. Well, let's start with an excerpt from Dear Abby. She writes in, Dear Abby, I've read you for years, but this is my first letter to a newspaper column. I love and care for an aging parent. She is in her 80s and requires constant care. Bathing, feeding, etc. I do this routinely, 365 days a year. My husband and I haven't had a vacation in 11 years. I get a sitter for a few hours occasionally, but it's expensive, so I don't do it too often. I need dental work, a physical, a chance to shop for clothes and shoes. Those who bear the full responsibility of an aging parent or a severely handicapped relative know how mind-weary and bone-tired one can become in caring for that individual. There are lots of people who are looking for hobbies to occupy their free hours, she writes. Why don't they ever think of telephoning people like me and saying, I'll come over tomorrow and you can be free for a few hours? Perhaps those lucky people who play golf and bridge and go to club meetings have never thought of what it's like to have a responsibility from which there is no relief. Generous folks give freely of their money, but they give nothing of themselves for others. Each day I think, maybe somebody will call today or even tomorrow. I am so tired. No name, she signs it no name, but that was an actual Dear Abby. As Mrs. Carter is known for saying, there are only 4 kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and those who will need caregivers. It is for that reason, and for people and individuals that wrote that letter into Dear Abby, that the Rosalynn Carter Institute for Caregiving became known. It was established in 1987 on the campus of Georgia Southwestern State University, and it functions to establish partnerships, local, state, national, and international partnerships that are committed to building quality, long-term home and community-based services. Let's talk about some of the caregivers. Over 50 million family caregivers provide the largest proportion of care for dependent elderly as well as adults and children with disabilities and chronic illnesses. There are approximately 6 million older adults who need daily assistance to be able to live outside of the nursing home, and that will increase to about 12 million by the year 2030. We all know that with longer life expectancy, we will have higher rates of chronic illnesses, disabilities, and the need for care. And last, I want to bring out the point that the average senior today will spend 2 or more of their final years disabled enough to need someone to help them with routine activities of daily living because of their chronic illnesses. We all know about the aging population and how this has grown astronomically. There we have a projection that in 2040, 79.7 million will be here. This is over twice where we were 40 years ago. So there are some general issues about all caregivers. Let's look at those. They do face an array of new challenges. We have smaller, more geographically dispersed families. They have competing child-rearing duties, and they're trying to balance work and caregiving. Caregiving is not a short term. Most times it's 5 years or longer in duration. It is much more technically and physically demanding. As a geriatric nurse, I know from the healthcare setting, we send you home from the hospital quicker and sicker, and we expect that family caregiver to step in and manage those medications and be able to manage wound care. So it's a much harder role today. Many caregivers are living with depression, and they have twice the rate of chronic health conditions as opposed to non-caregivers. I think as we age, and we've seen the population demographics are changing rapidly, we need to look at spousal caregivers. Many of them are older. 1 in 5 is a spousal caregiver. They are much more likely than non-spouses to provide assistance with medical nursing tasks, and they are less likely to receive support from family and friends. They're less likely to have home visits from healthcare professionals and aides. And many of them are living with isolation and stress. I think it's important that we look at the growing care gap. When 68% of Americans believe that they can rely on their family to provide for long-term care needs, we have to think of something what's called a caregiver support ratio, which is the number of potential caregivers who are age 45 to 64 for each person that is age 80 and older. In 2010, our stats showed us that there were 7 potential caregivers for each person in the high-risk years of 80 and plus. In 2030, which is rapidly approaching, there will only be 4 potential caregivers for each person in the 80 and plus group. Here's a chart that kind of shows you, and you can see as the baby boomers come onto age and they turn 65, that growing care gap, you can see how it is changing from 7 potential caregivers to 4 and then to 3 for each person that's over the age of 80. Caregiving can be like a marathon. You know, every caregiver wants to run that race energetically, and they want to run it with good speed. But respite is a vital element of that caregiver journey. Just like runners and marathon runners have to stop to get water during their run, caregivers need to stop for respite as well. Respite empowers that caregiver to sustain themselves in a very important role. And respite can be very beneficial and meaningful and enjoyable for both the caregiver and the care recipient. In a caregiving survey that we hosted at the Rosalynn Carter Institute, we asked caregivers, what is respite? This is what they told us. They said, it simply means getting a break from your caregiving responsibilities for a few hours or even a few days. It may not eliminate your problems, but certainly it can make you feel better and energize you so that you can face a new day. We also asked them to share their advice. We felt like that those who had lived the experience of caregiving and respite should have the best advice. And while we do realize that every caregiver's experiences are unique, the solutions that work for one caregiver may not work for another. But here's what they shared with us. One said, let go. Acknowledge that as a human, you have limitations just like everyone else. Allow others to help you and delegate. Practice asking for help and saying no once in a while. It really is okay. Another one said, learn relaxation techniques, and they stressed the importance of listening to music, taking some time for exercise, reading a good book, taking a walk. They advised to maintain a life outside of the caregiving role. Caregivers need to develop hobbies, learn new skills. One even suggested recording happy times with your loved one in a journal. Keep a daily burnout log. Record the events that cause stress in your life. And after several weeks, this caregiver said you'll be able to identify some problems and areas and maybe brainstorm about some solutions. Build a caregiver team. You don't have to face caregiving alone. Don't shy away from asking family members and close relatives to assist you, even if you do not think they will want to help. Ask anyway. Seek spiritual renewal. Religious services, talking with your clergyman, or individual worship can help to alleviate your stress and give you strength and inspiration. Appreciate yourself, one said. One said that all the caregiving in the world will not save a terminally ill individual. Diseases take their own course, no matter how diligently you may provide that loving care. Rather than belaboring yourself for your inability to cure what is incurable, draw strength and comfort from what you can do. You can provide dignity and care and love. You cannot control the outcome. That rests in God's hands. Rely on your sense of humor. A good chuckle can help you get through the worst of things. As a geriatric nurse and teaching many times, we always started our class with a joke. I have to share some with you now so we can have this humor. There were two elderly ladies who had been friends for many decades. Over the years, they had shared all kinds of activities and adventures, and lately, their activities had been limited to meeting a few times a week to play cards. One day they were playing cards when one looked at the other one, the old friend, and said, "Now don't get mad at me. I know we've been friends for a long time, but I just cannot think of your name. I've thought about it and I've thought about it, but I can't remember it. Please tell me what your name is." Her friend glared at her. For at least 3 minutes, she sat and just glared at her. And then finally she said, "How soon do you need to know?" One other I would like to share with you. There was an older adult called 911 one day on her cell phone to report that her car had been broken into. She was hysterical and she was explaining the situation to the police dispatcher. "They've stolen the stereo," she said, "the steering wheel, the brake pedal, and even the accelerator," she cried. The dispatcher said, "Stay calm, an officer is on the way." A few minutes later, the officer radios in. "Disregard," he says, "she got in the back seat by mistake." At the Institute, we have 4 areas of focus: advocacy, research, education, and service. And I want to share with you some about the programs that we have, because all of these programs have a relationship to respite. We have a CareNet coalition, and the CareNets are volunteer organizations that started in the 1990s, looking at how we might best service our family caregivers across the state. There are in Georgia 12 regional CareNets, one in each area agency on aging district. Who's a member of the CareNet? Anyone can be. They're all volunteer. There are people from churches. There are people from the aging services, people that are family caregivers of children that have autism, disabilities, chronic illnesses, the lot. But they get together, they exchange their time, and they exchange resources, host caregiving conferences each year. We also know that people get respite through learning and education. At Southwestern, we have now established the only one Caregiving Issues and Management Certificate program that is offered. It is 6 online courses, 3 credits each. They're academic credit, and we have rallied and we're given approval to offer these with a out-of-state tuition payment. So everybody gets a flat fee, and we have people across the nation and actually internationally that have enrolled in this program. We also have students that are in the caregiving fields that are learning. We have Pope scholarships. If somebody would like to enroll in one of those courses that I just talked about in our caregiving certificate, we have scholarships that are available for them. We also have interns at the Institute, with opportunities to work directly with caregivers. They have monthly meetings with a caregiver focus. This is a group of them here. Other actions that we do, and as Jill pointed out earlier, we do work with other states in state units on aging. We are trying to help states create a seamless statewide access to supports for persons with dementia, chronic illnesses, and their caregivers across the lifespan. In Georgia, we have been able to enjoy a grant partnership. They were funded by AOA, now ACL, and our role in there was to do assessments and looking at dementia capability, as well as roll out 23 webinars on this topic over a 3-year period. Right now, we're engaging with the State Department with their case management redesign and rolling out BRI care consultation, which I'll tell you about shortly, and how that works. Just recently, we were working with Nevada, and I see one of our colleagues here with that, and we're going to work with them to roll out BRI care consultation in their state as well. We have published a series of 9 books on research and policy, and you can see them listed here, but they are available on our website, and so you can look there. Thank you so much. Probably the most current publication is Mrs. Carter's second edition of Helping Yourself, Help Others. It is available on the website as well, but it really speaks to the critical need for caregiving respite. And it has a lot of stories in there about caregivers. Now let's change our focus a little bit. Let's talk about 3 evidence-based programs. Each of these programs has a relationship to respite and providing for respite in different ways. The first one, because we've talked about it just recently, is BRR Care Consultation in Georgia. This particular program is telephonic, and it's also will utilize the internet for this. It is evidence-based, meaning that it came from a randomized control trial originally, has been tested. It is 12 months long. You have a care consultant coach. They empower one to connect to their resources. It is very tailored to each family's needs, very supportive, and it is in the role of crisis prevention. Who benefits? The great thing about this program is the benefits are for those that are primary caregivers, secondary, and even long distance. You don't have to be right there with them. So in a snapshot, you can say that for individuals, care consultation provides assistance with health and care-related information, family and friend involvement, awareness and use of community resources, and coaching support. For agencies, though, it provides a computerized service delivery system, which we call the CCIS, in-depth caregiver and care receiver assessment, and the capability to run multiple reports. This is a personal testimony, and you can read the screen from a care consultation caregiver. They were very thankful for their participation in this program. When we were running care consultation in Georgia, and it's going now for the rollout, but we served over 600 people in 40 Georgia counties. This care consultation was sponsored, and we received funding from the Administration for Community Living. We found that one care consultant can effectively serve 75 to 125 caregiving families at a cost of about $1.03 per day. That is a very reasonable amount. And let me show you about some of the results that we're giving. The people that we've interviewed and we've done pre and post data assessment report an increased confidence in managing care. They have an increased ability to organize their family and friend helping network. They have an increased ability to get respite from caregiving. And they have an overall increase in their total needs being met from participating in this program. BRI Care Consultation has been utilized in other research studies, so I thought I should share some of those outcomes with you too. And they are improved care, reduced hospital admissions, delayed nursing home placement, fewer ER department visits, decreased caregiver depression and strain, improved quality of life, and improved access to information. So a very successful program. Now I want to talk to you about a second program, RCI Reach. REACH is an acronym for Resources Enhancing Alzheimer's Caregiver Health. It's probably a program that's very familiar to many of you here. It is a face-to-face intervention. It is intensive. It is evidence-based. It is over a 6-month period, and it is delivered in the home with a coach. It is tailored to client needs, and there is a caregiver notebook that focuses on common issues. It's very supportive in the caregiver journey. If you like, there is an option in RCI Reach that you can have a telephone support group, but it's very scripted on what you can talk about on those support group convenings. One of the topics is education about dementia, safety for the dementia care recipient, emotional well-being, health and self-care, social support for the dyad, troubling dementia behavioral problems. We've done 2 studies. In one study, we served 85 people in 11 rural Georgia counties. Again, this was supported by the Administration for Community for Living. One care interventionist can effectively serve 20 caregiving families because they are meeting with them in the home and they are traveling. It's very intensive, so your numbers are down because it's as far as how you can serve that many. The average cost is up just a little bit, $7 per day. In this particular program, we were doing a lot of traveling to those rural areas, and so our cost was elevated some. I see a lot of heads nodding, so you do run up dollars in those travel, in that travel capacity. In our second study, we were looking at the Georgia coastal area, and we served 121. One care interventionist can effectively serve that 20 still, but here are some charts that tell you about their outcomes as well. Decreased burden, decreased depression from pre to post, and remember this is over 6 months. An increase in their physical health. They're learning how to take care of themselves when they're working one-on-one with that care coach. There was an increase in our behavioral problems. You would think so, because as the disease progresses with dementia and Alzheimer's, those behaviors are going to increase. But what was astounding is that the caregiver's reaction or frustration or stress in having to deal with those outcomes, those problems, decreased. So it was a very positive thing. Now I have some exciting news for you. If you are here in the room, or anyone you know, and you're ready to bring an evidence-based caregiver support program to your community, with funds by the Administration for Community Living, we are now moving RCI Reach out across the nation to up to 20 sites free. So if you need the training and the technical assistance and consultation to up to 20 agencies across the nation, if you would like to apply, I would love to see you. This is new. It's a great opportunity to get this. I would ask that you would email Gail Austin. Her address is on there, and if you missed this, I have some cards that are down on the table, my business cards. Either one will do, but we'll put you in the right place so that you can apply for this great opportunity. And last today, I want to talk to you about a third group, a third population we serve, and this is your military caregivers. Currently, for Operation Family Caregiver, we have 4 sites. They're listed on your screen. Operation Family Caregiver is a program of the RCI. It is also funded initially through Johnson & Johnson. It is an evidence-based caregiver program. You know, when we talk about across the lifespan, military caregiving is one that hits across all ages, whereas a lot of them are young. 1 in 4 of the caregivers that are caring for these guys and gals coming back from Iraq and Afghanistan are over the age of 65. So you think about your older adults. But let's take a look at some of the statistics here I think you'll find interesting. Since 2001, 2.4 million active duty and reserve military personnel were deployed to the wars in Iraq and Afghanistan. 30% of this group, nearly 730,000 men and women, will have a mental health condition requiring treatment. 18% will have post-traumatic stress, and 1 in 6 returning will have traumatic brain injury. It's the families of those men and women who have gone to serve our country, that maybe gave a leg or an arm for our nation. It's those families that are standing behind them, and it's the families that they return to. At the RCI, we know that the families may not have worn that uniform, but those families certainly have served our nation, and we need to give back to them today. This is a direct quote from one of the sergeants here. He actually was at a Fort Benning, which is the largest military army, I would say, group down in Georgia, in the southeast, in fact. And he says, when these guys and gals deploy, they come back home with post-traumatic stress, traumatic brain injury, whatever the issue may be. A lot of the spouses I've talked to have all said the same thing. They do not know how to deal with their husbands or their wives when they return. Their families, whether it's their wife, their husband, or their children, suffer because they're not prepared for that change. Yeah, they get the nice little brief from ACS and the Family Readiness Group that your husband's going to come back changed, but they aren't given any tools or resources for when I didn't sleep, for when I woke up from the nightmares and I was punching her in her sleep because I didn't know where I was or what I was doing. The RAND report that came out in April of this year says that we need to empower these caregivers. We need to create caregiver-friendly environments. We need to fill the gaps in the programs, and we need to plan for future caregiving needs. The RAND report gave us a very comprehensive landscape of what is going on with the military caregivers and where the needs are. They found that they are mainly younger. More than 40% are between 18 and 30. They're caring for an individual with a mental health or substance abuse condition. Largely, they're non-white, they're a veteran, they're employed, and amazingly, they are not connected to a support network. 53% lack that caregiving support network. Most of your relevant programs and policies serve caregivers, military caregivers, only incidentally. Most of them are targeted toward the care recipient, not the family. Most of them limit eligibility to primary family members rather than that battle buddy that comes back and is taking on the care, which we see a lot of. And many programs are geared toward caregivers for older populations because the eligibility says you have to be at least 55 or older to receive services. So there are some limitations there. And caregiving for these groups does impose a very heavy burden. Worse health outcomes, greater strains in family relationships, more workplace problems. They have an elevated risk of depression, and 33% of them lack health coverage. You might say, well, why is military caregiving unique? It is different. They are coming home with multiple and severe injuries or illnesses, not just one entity to work with, but multiple. There are very complex systems of care that they're facing and having to navigate. Some of the wounds are invisible. They're not able to see by the eye, and they require around-the-clock care, sometimes in a lifetime of care. As I mentioned, the interventions that we utilize are derived from randomized control trials. This is the manuscript from one of those. I want to talk about our programs, Operation Family Caregiver. It is a non-clinical, supportive adjunct to any support the family is receiving. The program is in addition to anything else the family is getting. If they're getting a lot of support from VA, this is just an add-on. A medical or mental health diagnosis is not required, and it does take the basic education a step further to facilitate behavioral change. It's all about problem solving and skill building. There is a caregiver notebook that we have designed. It was vetted by veterans for these families. So as we look at this program lasts over 4 to 6 months. We know that behavioral change takes time, and learning how to deal with the stress and learning how to deal with the frustration and problem behaviors that arrive out of post-traumatic stress. So there are 4 in-home visits. The visits can be done in person or by Skype. They're all face-to-face, but they don't have to be in the home. They can do it by computer with them. They also have additional monthly telephone availability. We do collect data at the beginning and the end. Our program philosophy is that we are teaching these young caregivers, and sometimes older ones, to face today's problems, but also get ready for tomorrow's challenges, because they're certainly going to be there. We believe in the philosophy that give someone a fish and you feed him for a day, teach someone to fish and you feed him for a lifetime. Operation Family Caregiver is confidential, it's free, it's very private, it's evidence-based. There are no medical records accessed. It is proven effective, tailored. You can do it in the home or you can do it via Skype, and it minimizes the stigma of reaching out for help, especially for those wounds that are invisible. Our impact is measurable. We are seeing a reduction in caregiver depression, a reduction in burden, an increase in the satisfaction of life, and a decrease in health issues. Here are just a few bar charts that back that up, with a decreased burden and decreased depression, decreased health complaints, increased life satisfaction. And we were teaching them about problem-solving skills. What we're seeing now is remarkable, that their ability in the positive problem-solving skills is increasing, and the negative problem-solving skills, where they don't cope well and don't handle it, is going down. So that's a great outcome. Just recently in April, in this particular picture, I was with Mrs. Carter, and she was invited to speak at the White House and make remarks at a military caregiving event. And here you see Senator Dole, myself, Mrs. Carter, that is a military caregiver there, First Lady Michelle Obama, Dr. Jill Biden, and on the last of his is Kathy Kay, which is one of my board members. Now I have time for questions and answers. Jill, still have time? So if anybody has some. And I plan to be here for several more hours, and so if we need to talk one-on-one, we can do that as well. Questions?
Is the notebook online?
For the Caregiver Notebook, it is not online. Once we establish, you have a great question, Susan. We established the Rosalynn Carter Institute Training Center, where we can teach. We have master trainers in all the programs that I talked with you about today. So as we go to that, we know that there's staff turnover in many agencies, and your program walks out the door many times when your person walks out the door for another job. So we instituted this training institute a couple of years ago. And so when we come and do the training, then the notebook comes as part of that training package. So multiple copies of it. So good question. Well, I appreciate the time to share with you today. It's remarkable, and I hope I get to speak with each one of you individually as we have some time as we move through the day. Thank you.